There is a healthcare epidemic going on in the US. I'm sure many of you already know, but it is so interesting to see year after year patients coming into the ED, and one factor is responsible for a huge number of the cases that we're seeing. What is that factor? Well, it's blood sugar, insulin sensitivity, and essentially prediabetes and diabetes as a whole. Now, prediabetes is affecting millions of Americans, and it's a completely silent disease. Insulin resistance occurs years before glucose actually becomes abnormal. And so today we're actually going to break down how blood sugar regulation works, why it's so important to control, why insulin sensitivity is so crucial to control, and what we can do about it, what tests we can take to check and monitor ourselves. And then in future videos, we're also going to talk about therapies. We're going to talk about lifestyle interventions. We're going to talk about hormones. We're going to talk about peptides. We're going to talk about pharmacological medications. And so today we're focusing on the fundamental cornerstone of the healthcare system and what's driving so many conditions today: diabetes, prediabetes, and blood sugar dysregulation. So let's go back to the basics. Glucose is your body's primary fuel source. In normal amounts, it's completely healthy. Your brain needs it, your muscles need it, your organs need it, and for optimal physical performance, it's very beneficial. But what's the problem with having too much gas in the gas tank or too much fuel in the engine? Similarly to running an engine too rich, how that can cause problems, having too much glucose in your serum can also cause problems. Having too many particles of glucose will allow for these particles to actually start adhering to nearby structures, right? Whether that be your red blood cells or your arterial wall. That process is called glycosylation. Glycosylation is bad, especially for your arterial walls, because it stiffens them. What does that sound like? That sounds like atherosclerosis, which is essentially the process of plaque buildup, right? Plaque buildup is bad because it can lead to things like heart attacks, pulmonary embolism, etc. And if your arteries aren't as compliant, if they're not able to expand and contract as well, this is going to lead to high blood pressure. High blood pressure also leads to increased shearing forces on the arterial wall. You can see how this creates a lot of downstream deleterious effects. So it's very important for your body to regulate glucose in a healthy, normal physiologic range. So when you eat a meal, right, with carbohydrates or anything that will increase your blood sugar, your body needs mechanisms to reduce that blood glucose into a healthy, normal range. In comes the pancreas and insulin. Now, the pancreas have beta cells which release insulin. Insulin is released in response to blood glucose, and insulin acts on skeletal muscle, the liver, and fat mainly to translocate what are known as GLUT4 receptors to the cell surface. Now, normally these cells will have mechanisms to remove glucose from the body, right, from the bloodstream, and take blood sugar from the bloodstream as they need it. But with insulin present, this allows these cells to kind of take up the blood sugar at a much, much faster rate. You are opening up the floodgates per se. So GLUT4 translocates to the cell surface and evacuates the blood glucose from the blood sugar or the blood. Now, this is good, right? This lowers the concentration of glucose molecules floating around in the plasma, thus leading to less glycosylation. Now, the problem occurs when you have too much glucose for too long of a period of time. And this is the process of insulin resistance. When you chronically have high blood glucose due to inactivity, high carbohydrate, high processed sugar diet, lack of sleep, increased stress, just poor lifestyle factors, as well as genetics play a very important role here. Your body becomes less sensitive to insulin signaling. Similarly to how you develop an alcohol tolerance, when your body is used to dealing or seeing a lot of insulin, the receptors that trigger the GLUT4 translocation now downregulate. The receptors themselves require more insulin to have the same effect. Over time, that's okay. Your body can do that. Your pancreas is able to produce more insulin. So that's what it does. Your pancreas says, okay, let's make more insulin. And this is the process, and this is kind of the period of prediabetes, where a lot of your blood markers might look okay. And a lot of the standardized markers that we're testing for, if you're just going to a general practitioner, you could have insulin insensitivity, but you would have completely normal markers if you're just testing basic blood labs with your PCP. If your body is able to compensate, your A1C, your hemoglobin A1C could be normal, but you might just be producing more insulin. So the process of prediabetes is where that compensation really begins to break down and fail. This process is often reversible, and there are numerous studies showing just how beneficial lifestyle changes and certain medications can be when it comes to reducing or reversing prediabetes completely. Diabetes is essentially the endpoint of prediabetes, where your pancreas essentially gets burnt out. The beta cells are no longer functioning and your body is not producing the insulin required to take the blood sugar out. Now, this has extremely deleterious consequences to your health, not only in the long term, but it can even be in the short term. And it's something that we see in the ER all the time. Patients with diabetes come in with diabetic ketoacidosis, which is essentially a condition where your blood becomes extremely acidotic. And if not corrected properly, in the correct way and acutely, in a fast way, you could die. Now, if that doesn't get you, you could also fall victim to diabetic retinopathy. Your vision starts going. This is one of the first areas that you will notice decrements in. Nephropathy. So your kidney, you'll start having kidney issues. You might require a kidney transplant. Many patients that I see have kidney failure secondary to diabetes, and now they're on dialysis for the rest of their life or requiring a kidney transplant. All of these things require insane amounts of medical intervention, and you will never live the same quality of life as you did before. Neuropathy is also extremely common, something I see all the time. You lose sensation in your feet and your legs. It's no big deal. You just, maybe you have a little bit of tingling in your legs. Next, it requires a toe amputation. Next, a foot. Next, a leg. And these are not procedures that, once you lose your legs, you just get your prosthetic. No, a lot of the times you can have phantom limb pain that essentially makes you feel like you have this excruciating pain as if you still have your leg even though it's gone. Next, cardiovascular disease. People with diabetes are at a severely increased risk for heart disease for the reasons that I stated before, right? Your arteries are a lot stiffer than they were. Next, you have cancer risks. Cancer thrives on glucose. Cancer thrives on high amounts of blood sugar. This is really kind of anabolic. This is rocket fuel for cancer. So if you have diabetes, you are at extremely increased risk for cancer. Strokes as well. Just like heart attacks, the blood vessels in your brain are going to be susceptible to clotting off. Right? You're not going to have that same elasticity, and you're going to have also risk for more clots. And then finally, Alzheimer's disease is another huge thing. Type 3 diabetes is kind of known as this idea where these small blood vessels in your brain that are required to get these kind of distal terminal portions, these terminal regions of your brain that perfuse those regions that kind of keep your brain healthy and functioning, are no longer going to get the perfusion that they once had. And now you're kind of losing neurons, right? Your neurons are dying. So you're quite literally getting dumber over time. How do we get adequate testing for this? Well, first, fasting glucose is the staple, and this is something that your PCP will get you. It just measures your overnight fasting glucose with an optimal range being between about 75 to 90. Normal can be 70 to 100, but again, there's a lot of variation in what I'm saying. So if there is just any singular one number that is off in your blood work, this is not cause to freak out. This just means you should consult your physician and have a conversation. Now, prediabetes, the prediabetes range is where you find your fasting glucose to be between 100 and 125. This, again, is not too different between the kind of 70 and 100 or 75 and 100 range that I referenced earlier, right? You could be at 105, 110. This is not that dangerous in and of itself, but again, it is leading to this slow damage over time. Now, diabetes is where your fasting blood glucose is now over 126. This is going to be full-blown diabetes where you probably need insulin to manage your blood sugar. Next would be hemoglobin A1C. Hemoglobin A1C is a marker on your blood cells that reflects the average blood glucose over the past 3 months. So better than fasting glucose, because fasting glucose can change for a variety of different reasons, right? Fasting glucose can change because you're stressed, you got poor sleep, you just had a workout. Whatever the reason is, fasting glucose is going to be a much more sensitive number, but it's not going to be something that you can really rely on with a single data point. Hemoglobin A1C is that average. So this is really what the PCP, what your general practitioner relies on when they're looking to diagnose you with diabetes. Now, the optimal range, I would say, for an A1C is below 5.3%. A normal range that is thought to be non-prediabetic is below 5.7. Prediabetes is now 5.7 to 6.4, and then full-blown diabetes is going to be greater than or equal to 6.5%. Next would be a continuous glucose monitor. This is not something that I recommend for everybody, but I think it's very useful in an optimization context, or especially in those that are at risk for diabetes. Like if you're pre-diabetic, this is something where I would start to recommend it for you. Or if you're just somebody who's really interested in optimizing your meal timing, optimizing meal choices, right? Food choices, sleep habits, sleep patterns, seeing how it affects you in real time, this can offer really valuable data. But it measures your interstitial glucose every few minutes. So that is going to be the glucose that sits kind of between your cells. The blood plasma leaks between your cells, and it's going to be measuring that, and it just sits right on the back of your arm. So again, it's useful for measuring the meal spikes, variability with exercise, sleep, stress, alcohol, et cetera, et cetera. There are really no diagnostic cutoffs here. It's more valuable to see the trend over time. Now, I think one of the most useful tools that we can use to evaluate somebody's insulin sensitivity is going to be an oral glucose tolerance test. This is a pretty invasive test, and not to say that it's painful or anything, but it is something that you're going to have to go into a clinic and do, and it can be a little bit of a headache, but it provides by far some of the most valuable diagnostic information. So it's going to be a protocol where you come in, you fast for 8 to 12 hours, and then you draw a baseline fasting glucose. Next, you're going to drink 75 grams of glucose within 5 minutes. So you just essentially take a shot of an extremely sugary mixture, and then you measure the glucose at the 2-hour mark, and you can even do it at the 1-hour mark, and you can see how your body handles the glucose load. If you have persistent elevation in your glucose, that's how you can notice you have insulin resistance, right? Because if you just see your fasting measurement and it looks okay, your body's able to clear that glucose eventually, but your body's not able to clear it efficiently. And the longer you have this elevation, the longer your body and your arteries are being exposed to glycation. So a 2-hour glucose test, right? The optimal would be to have your glucose be below 120 milligrams per deciliter. Your normal range would be about 140. Prediabetes is 140 to 199, and then diabetes is 200 or greater. But let's just say you don't want to go the OGTT route. It's a lot of work. You don't want to go to the clinic. You don't want to have to drink all those calories of pure sugar. You can take a fasting insulin, especially if you're somebody who doesn't have a lot of risk factors. You don't necessarily need to take this test, right? If you don't have a family history of diabetes, if you are on top of your kind of lifestyle, if you have a otherwise healthy diet, every other marker looks regular or in range, is optimal, you don't necessarily have to do this highly invasive OGTT test, even though I think could be very interesting as a data point. You can just do a fasting insulin. Now this just measures your basal insulin secretion, so your just normal insulin level at a fasted state, and it will show you how hard your pancreas is working, right? If at a fasted state, when you haven't eaten for 8 hours, you have elevated insulin, your body is still trying to clear blood glucose. It's requiring 10 units for what a healthy person's 3 units could do. So the optimal range is just going to be 2 to 5 micro IUs per milliliter, but there really are no diagnostic cutoffs here. So again, this can just be used as a trend. But this is going to be able to tell you, is your pancreas having to do the work of 3 or 5 pancreases for a normal person? The final test or calculation that I would perform for insulin sensitivity is a HOMA-IR. Now, this isn't necessarily something that is going to be the most useful in my opinion, but it is, again, a useful data point to track and trend over time. It isn't an actual lab test in the sense that this is something that we're measuring in the blood serum. It's actually just a calculation, and it uses 2 variables, your fasting insulin and your fasting glucose. Optimal levels or optimal HOMA-IR scores are going to be below 1, with a generally favorable score or a normal score going to be below 2. 2 to 2.9 suggests early insulin resistance. Over 3 suggests significant insulin resistance. But again, there are no standardized cutoffs here. Finally, there are some ancillary tests that I would like to mention that I think would be valuable to get as surrogate markers or reasons as to why you might have elevated blood glucose, right? Stress and cortisol are a big driver for elevated blood glucose and thus can lead to insulin resistance. So getting a fasting cortisol, and then also a TSH and a free T4. So your thyroid hormone is, again, a really metabolically kind of involved hormone. So testing your thyroid function is going to be extremely important. If you're hyperthyroid, your body could be increasing blood glucose because your liver is releasing more glucose in response to an elevated metabolic demand. So these are the tests that I'm going to recommend for everybody to screen comprehensively for prediabetes and diabetes. It's going to be TSH, free T4, cortisol, fasting glucose, hemoglobin A1C, and a fasting insulin. If you're doing that, your bases are covered. If you want to optimize, then you can now go into the HOMA-IR, you can go into the CGM, the continuous glucose monitor, or you can even go ahead and get an OGTT. So overall, diabetes and prediabetes are an extremely pervasive issue within our modern healthcare system today that is being grossly mismanaged. And it's the reason that I see patients, a huge majority of patients presenting to the ER for a direct cause like diabetic ketoacidosis or an indirect cause like a heart attack. But with these tests, you can stay on top of it. In the next videos, we're going to talk about how to manage it. Please like, comment, subscribe if you enjoyed this video. Let me know what you thought about it down in the comments, and we'll see you in the next video.